Welcome to Acute Conversations, the official podcast of APTA Acute Care, where we share engaging conversations about acute care physical therapy so you can connect to your profession. I'm Ashley.
And I'm Leo. Today we chat with Bento, Bryan Lohse, and Paul Arnold, all hailing from the University of Utah. Haley is an assistant professor and the director for the acute care and cardiopulmonary residencies. Bryan is a cardiopulmonary specialist PT in the ICU, and Paul is an occupational therapist, also in the cardiac ICU. Today we discuss why co-treatment is negatively affecting our profession, the benefits of separating services,
and the special ingredients required for an acute care Sunday. Let's welcome our guests.
All right, everyone. Thank you so much for listening to the podcast today. We've got some great guests. We have Bento, Bryan Lohse, and Paul Arnold, hailing from Salt Lake City, Utah. And I just want to make it clear that today is the first time on our podcast, Acute Conversations, we have Paul Arnold, an occupational therapist that is joining us in the ranks today. So we're all going to clap for Paul. Actually, Paul, Haley, and Bryan, thank all of you for coming to the podcast today for a recording and to talk a little bit about the concept of co-treatment, working with PT and OTs and the interdisciplinary interaction and when it should be utilized and when it should not be utilized. So I'll pre-frame this with a really quick story. I remember, I think it was a couple years ago at CSM, and this is why CSM is always so fun to go to. I remember seeing Haley and Bryan. It was after, I think, the acute care meeting, and it was so great just hearing. I remember Bryan, I remember you hearing you talk about how do we prioritize patients. Are we there as a consult service or are we there to provide treatment? So I think that was a great conversation. I go back home and I look at my PT magazine and this lady who I met at CSM is on the cover. I'm like, oh my gosh, it's Bento. That was who I was.
I remember that cover too. I was like, I know her.
Right. Yeah. I brought it. So next time, Haley, next CSM, I'm going to bring it so you can sign and I can put that up because I think you have it in your office too, correct?
I sure do. I've got a copy that's signed. So the two students that are in the magazine picture with me, they're from our class of 25. I had them sign it, made sure that they know that'll be up in my office for the rest of eternity. So that was my 1 minute claim to fame. And I think that magazine actually came out. A lot of people received it right before CSM. So I had a lot of really strange people recognizing my face all over CSM that year. It was fun.
That's great.
Well, why don't we start off with I know you had presented, I think all three of you had recently presented at CSM on this topic of co-treatment. Why don't you kind of maybe just talk through what were some of the information that you had shared with everyone there?
Yeah, they were at CSM 2023, and then they also did a webinar. So if our listeners were at either of those, you've probably heard a little bit of this before, but hopefully we can dive a little bit deeper today. But yes, please give us an overview of what you all have presented thus far, and then we'll ask questions.
Bryan, you want to take that one?
Sure. So we kind of came up with this idea for this presentation a little bit organically. I was talking with my boss before the CSM 2023 submission deadline, and he was like, you should put together a presentation about what you guys do because it's unique. And we started talking and we said, this is a great idea. Let's submit it. And we put together a talk on just kind of how we've developed our practice on our ICU over the years, where we've really tried to be intentional about the therapy that patients are getting, and we've tried to be intentional about maximizing the right service with the right patient at the right time. And a lot of that has come with this idea of not seeing patients together with PT and OT at the same time and having individual services. Our topic at CSM really was just about covering that. I'm trying to think about the other details now, but I was sort of expecting Haley to take this one. But
yeah, well, I'll chime in here too. I guess part of what we really are trying to bring the conversation as well is the OT perspective. So Paul's with us here today. We're going to get a chance to hear his thoughts. And, I know he doesn't speak for the entire OT profession, but we as PTs, we often co-treat with OT and we maybe don't have a clear role of if that's beneficial for our professions. and for our patients. So we're always trying to look internally and figure out what we can do differently to make a better impact on our patients. And we also need to be thinking about our professions and longevity. I don't know how people look at us professionally and our professional roles and goals. And as acute care therapists, we all know it can be really an uphill battle to sell people about what you do and why you do it. And I think OT has an even more uphill, steeper battle. And co-treating is just one of the ways that maybe complicates that for both professions.
That's interesting too, because I felt it was maybe 2 years ago, back in 2023, there was this conversation about about why you should co-treat. That was kind of pro co-treatment. And so maybe we're like rubbing elbows a little bit in terms of what we're saying. But again, we have to dig a little bit deeper. There's got to be a why for the clinical decisions that we make.
I'm curious, Paul, from your perspective, like, what was your practice like before? Were you all kind of going around arm in arm co-treating, and then you're like, hey, why are we doing this? Or were you both kind of just like, you know what, like, we need to talk about this more because I feel like our patients will benefit from more therapy versus less therapy? Because you hear on the other side, like, well, we co-treat because the patients don't want to answer the history questions twice, right? We're asking the same questions. Or we co-treat because the patient's too tired to do another session. So I'm kind of curious, like, how did this all start for you all? And kind of what was your practice before, and how did you make that shift?
Yeah, that's a great question. I think so. I started practicing a few years ago, and initially when I was trained right off the bat, it was demonstrated to me this pattern of co-treating and co-evaluating and the like. And soon on, after beginning my career, I was noticing that it was almost synonymous, OTPT in the room, or even in physician notes or in discharge summaries, PTOT were written on the same line as each other. And just to point out one experience, I was working with a patient after a transplant, and I was doing what I thought was just a primo OT session with this patient. And a provider came into the room and said, "Oh, pardon me, I didn't mean to disturb the PT session." And, you know, I'm not going to take that too hard to heart or whatever. I really appreciate and respect and look up to the PT profession and consider ourselves siblings. But I want to be known as my individual service and what I can provide and offer, what value I can offer.
Yeah, absolutely.
And so I said to the individual, I was like, "Oh, we're actually doing an OT session if you want to hang out for a little bit." And their rebuttal was, "Oh, I just always say PT." And it kind of made my heart sink. Like, oh man. And I didn't take it any further than that. And I'm not going to hold that against that individual. But I think as occupational therapists, we maybe haven't been doing a very good job marketing ourselves and what we can do. And by always walking through the door together, PT and OT, I think it kind of muddies our practices and it reduces our ability to be more specific and more potent with our treatment sessions. And I've had a great interdisciplinary relationship with Haley and with Bryan, and we collaborated together to coach each other and to work side by side, but to still respect each other's ownership lanes. And I think what we've been able to do by doing that is build a stronger team. We've been able to build a greater sense of interdisciplinary respect for each other and trust too. And so I think that's where it stemmed from, where just these small interactions where I was feeling like I got to do a better job marketing my skills and what I can bring to my patients.
It's so interesting you say that, because you're so right. I mean, so many other people will just kind of group it together like PTOT or OTPT. And you're like, no, we're completely different. And I can remember a story where I was in the hospital. I was working on the cardiology floor, and one of the heart transplant doctors came up to me and he said, "Actually, let me ask you a question," because we had developed a really good relationship. And he says, and I think he was coming from a very vulnerable place, which I appreciate, but he said, "What is the difference between PT and OT?" And I was like, oh my gosh, like, it's such a simple question, right? But like, he really did not know the difference. And I think you're right that if we can learn to distinguish ourselves, not only do they no longer group us together, but we probably stop getting some of the inappropriate consults too, right? Like OT has a very different scope of practice than PT. Yes, there might be some overlap, but they often always put those consults in together, and it's not always necessary. So it's really interesting that you say that.
Yeah, and I think from a business perspective too, right? We need to be thinking about the implications on that, on staffing in the future. If
Yeah.
people don't know what our value is and can't tell us apart, and they go to cut staffing, I worry that OT will be the staffing that's cut because they don't understand the value and they do just see them as PTs, which they're not. They have a very, very unique value, and we need to be highlighting that and differentiating ourselves from them so that people can see that value as well.
Yeah.
Absolutely.
Paul, I think your story resonates with, working with a number of OTs over the years, both as during some co-treatments and just kind of different staff meetings and just having that conversation. I think your story resonates with them. And what I appreciate is the fact that you didn't necessarily take it from a confrontational standpoint, but you said, you looked at it internally and said, what can we be doing? What can I be doing to kind of educate the staff members, right? Because I've seen both PT and OT react very aggressively and very angrily, and I can see why they can be frustrated, but not making it an opportunity to be able to teach some of the allied health staff. Okay, this is what PT does. This is what OT does. And I've heard different ways OTs explain what they do, and the joke is always occupational therapy. I already have a job. So from your words, and again, I've heard it explained differently. What can we as therapists, maybe as physical therapists, maybe say in terms of that differentiation between OT and PT?
Yeah, that's an interesting one. I don't mean this as a cop out to avoid the question, but I really think it's going to depend on the setting that you're in. Different settings are going to demand different things, and there's different types of value that you can add. And I had to sit down and ask myself, okay, what interventions and tools do I have in my belt, in my workshop that I can bring forward? And what value is that going to provide the patient? And so as far as working in a critical care setting, background is working on a critical care cardiovascular unit, a lot of CT patients, cardiovascular patients. And going in and diving into the research found that there were a handful of interventions regarding delirium reduction and prevention, regarding role reintegration, regarding ADL remediation and IADL remediation. And I think those can be distinctly occupational therapy interventions. We're living, I believe, during a bit of a renaissance in the therapy world where there's a lot of budding evidence, and this body of evidence is continuing to grow. And I think it's going to require us as individuals on a grassroots level, as well as a national level, to really say, what can I do right here within my sphere of influence, within my framework as an OT? What can I do so well that nobody else can do it? Mm-hmm. And so I think it's going to require a little bit of introspection on the individual's part, or on a department or systems level, depending on where you work.
Mm-hmm. So I'm kind of curious. I want to shift gears a little bit. We've talked about like the benefit of co-treating in terms of like distinguishing our professions from a marketing standpoint, a business standpoint, a consult standpoint. But what do you say to those people? Like, what are the benefits to the patients? The people that are like, oh, we don't want a patient, they answer the same questions twice, or the patient's going to be too tired, they're not going to be able to do 2 sessions. But what have you all found to be the benefits to the patient in those co-treat sessions, or non-co-treat sessions, I should say?
I'll take this one. I really think it has allowed us to think about our practice even more going in. Like if I know that Paul has this patient on his radar at some point today, I'm going to say, Paul, what time are you thinking roughly? I mean, it's acute care, so you never know. But knowing what Paul's focus is and what Paul's skill is, I'm going to say, hey, I'm not going to completely gas this patient right now. I'm going to titrate down the level of intensity slightly, but focus in on what I think is still beneficial in the moment, and put the patient in a position to be able to have another session later. I think if you look at all of the literature as a whole, and I think if you took an informal survey of all acute care therapists, we all tell patients frequent, shorter bouts of activity. And if I know that Paul is going to go focus on this, on whatever he's doing with the patient, I'm going to titrate it so that maybe the patient just needs an hour between our sessions, or 3 hours maybe, but I can still do quality treatment that allows the patient to have the time and energy to be able to work with Paul later. And then the patient's getting a second session.
That's one of the challenges we've worried about with a frequent co-treatment, is there is an opportunity cost for our patients. If we both go in at the same time and we do a solid session, it might have been a really good session with us together, but now the patient only had one session when they could have had 2 or 3 sessions. And simultaneously, there's a patient in room 22 that was not seen during that session that may have been seen. And so some of our fear is that we won't be having as much breadth at the same time. A lot of the work by Schweikert and Pullman, by Dale Needham, have really shown that those short but frequent bouts of effort are what's going to benefit our patients the most, just to echo what Bryan said.
Well, to me too, if they're getting 2 sessions a day and you're trying to recommend inpatient rehab or acute rehab, there's better justification for that as well, right? But I'm also curious, like I'm just imagining in my brain, like what people might say, what about the patients that they say requires 2 sets of skilled hands, like it's a max assist of 2? What do you do in that situation? I got all the counter arguments for you, just because I feel like somebody needs to play devil's advocate.
That's right. That's right.
Practice.
There's a lot of counter arguments, right? And at CSM this year, if anybody went to the Oxford debate, it was fantastic on this topic. I used some of our materials from our previous presentation on this, and we had kind of surveyed those top 5 topics and kind of came back with rebuttals about, like, yeah, there are of course patients that need more than one pair of hands, and we want to challenge people to think about other people, right? And the question or the rebuttal we always get to that is, well, the nurse isn't trained to help with mobility like somebody else, like another OT is. And I'm like, well, you could train them. Like, they're working in inpatient settings, mobilizing patients is part of their job too. So that's something that we've really focused on at University of Utah. We've created a very robust nurse training program where all new nurses on our unit, and many other units in the hospital as well, spend an entire day with therapy. And that's not just PT, that's PT, OT, and speech, to learn about our roles, learn about our goals, learn a little bit about our education and the place that we come from when we come say, hey, I'd like to work with your patient and do XYZ. They know that we maybe have the skills to do that, or why we're asking about those things. In addition, a large part of this training is to give them those hands-on skills. We do practice hands-on skills training, transfer training with them, and get them really comfortable. And all of the nurses on the unit are so comfortable jumping in and helping with those max assist of 2 transfers. Like, they all are, and they're incredible at it. And we as PTs are extremely skilled at not just doing transfers ourselves, but teaching other people how to do transfers, right? Like, we're educated in that, between family and other caregivers, to provide that level of assistance. And I think the ICU is no different. And if you train your aides, train your HCAs or CNAs, train your nurses on how to help with mobility, they can be a great asset to that, and that can help free up OT. In the same breath, if you're just using OT for another pair of hands, like, we should be using them for their brains, not just their hands, right? There are other people with hands and muscles.
Haley, I just want to refer back to our very last podcast where we had Jason Falvey on, and one of the things that he had talked about, again, he was the Acute Care Lecturer Award. One thing that he talked about was the amount of value that we bring as therapists, not only when we're face to face with the patient. So Bryan and Paul, just hearing your interaction, how often do we do that where we coordinate? Because that's the interprofessional coordination. It's not always just bedside with the patient, just to say, okay, Paul, I worked with this patient in the afternoon, and I spoke about OT, and I let them know that OT is going to be coming around this time in the afternoon to be able to work on more therapy, and vice versa. And Paul, how did this patient do in the morning? Is there anything that I should kind of focus on? So all the other things that we do outside of just bedside. And then, Haley, I love the fact that you brought up our ability to be able to teach. There's so much value that goes into that as well. Our ability to be able to teach some of the other staff members how to perform, so that in the long run, the patients benefit the most, right? And so again, they can get these frequent opportunities to be able to participate in therapy, short frequent bouts. And then again, it's reinforced by the literature. So for those of you that are out there that wanted to kind of learn more about what's actually being implemented at the highest level, at the top of our practice, short, frequent bouts will benefit the patients the most. That's great.
Attention acute care members. The Bridge the Gap Conference is coming to Chicago, Illinois, May 3rd to 5th. The theme is Translating Evidence into Acute Care Practice. The conference will be focused on bringing the science and evidence for physical therapy into acute care practice. The conference will be featured in stunning downtown Chicago at the Department of Physical Therapy and Human Movement Sciences, Feinberg School of Medicine, Northwestern University. Once again, May 3rd to 5th. Registration is now open and is available to the first 96 attendees. Register early to secure your spot. Early bird registration closes on April 19th. Please check out our show notes for a link for conference registration and agenda. And now, back to the show.
Speaking of the literature, Leo, that brings me to another question. When you are preparing for the presentations at CSM and your webinars, is there any evidence out there to support co-treatment or no co-treatment? And if not, like, what do we need to do as a profession to get more evidence out there to support this?
I'll take this one because I spent many, many hours trying to find the evidence. And I truly think that there was, in many of the articles I read and searched, there was one article that it was a single patient case study that they looked at when they co-treated and when they didn't, and made there were 4 co-treatment in specific scenarios, but that's it. If you really look at some of those landmark studies and really look at the wording on PT and OT, you could look. It doesn't say PT and or OT. It just says PT and OT, and so but they don't talk about it specifically. And so there's nothing. We need to publish in this area.
And
So anybody, I was just going to say, is there anybody looking for a study out there? We got an idea for you, right?
Yeah, we are. And I know there are a few groups out there that are interested in looking at this, but we're still at even the survey phase. Like, we don't even know what's going on out there, right? Acute care is such this wide array of practice. And, from speaking at CSM and talking to people that practice all over the country, we know that hospitals range from people that co-treat every session every day to people who say they have never once co-treated in their entire life and they hate it. Their hospitals don't allow it. Their hospitals encourage it. I mean, there's just no standardization across the board.
Yeah.
And part of it, we've also done pretty exhaustive searches into the guide to PT practice, the guide to OT practice, things like that. And there, we don't teach anything. We don't have any guidelines, which is okay. Like, we don't need strict guidelines, protocols on this, but it's a topic that needs to be discussed. And that when we don't have guidance, people often, it's just human nature, right? To do maybe whatever is easiest, like take the path of least resistance. And what we want people to think about is that may not always be what's best for the patient. And that's ultimately what's important about our jobs, right? Is doing what's best for the patient, even if it makes our jobs a little more challenging.
Well, and then there's the topic of billing, right? From an ethical perspective, right? Do we bill twice for that session where we're both in the room, right? And I think technically we can, but it's interesting. I teach an acute care certificate series for MedBridge, and I also teach an acute care course now at where I work. And so I actually did some research on this, and CMS actually says you should not co-treat unless it is absolutely necessary, and it should be a last resort. And they actually recommend a staggered approach. So maybe OT goes in, does some ADLs at bedside, right? And then PT comes in just for the 5 minutes that you might need those 2 sets of skilled hands to do a transfer, work on sit to stands, and then OT leaves and PT does their thing. So it's really interesting that even from an ethics and a financial economic perspective, there is a guideline, at least from CMS, out there. So I was curious what your thoughts were on that and what you've explored in that area.
Well, and to add to that, though, we know most of those guidelines are outpatient based, right? We as acute care therapists, we often have to follow outpatient guidelines in lack of guidelines specific to acute care. And acute care billing, as we know, is a whole different beast. It's kind of fun and money, right? what we're billing doesn't equal what we get back from insurance.
Right.
So it's really, I won't say it's a gray area because there certainly are legal implications to billing, but we don't have clear-cut guidance. And, what we're following, a lot of people say, well, that's outpatient guidelines, it doesn't apply. So there's, I think that there's more of a need to come out with stronger statements and recommendations for best practice. And some of that will be maybe looking at the data surrounding values, surrounding PT utilization, OT utilization. From a monetary standpoint, I think that health systems need to be considering that.
So for all of you, I was thinking about some of my newer grads, or maybe even some of my students that are on their acute care rotations, and how they should start looking at, there are sometimes situations where maybe as a PT student, they have to go in with an occupational therapist, and sometimes it'll be a co-treat or it'll be kind of like a handoff. But also this whole concept of, I remember being a new grad and it always felt better to go in with just an extra set of hands, right? Or just, there's two brains, there's four hemispheres all going together. And I've seen new hires come in where here's the newest OT and here's the newest PT. They both on board at the same time. They met at orientation, but it almost seemed like every single evaluation, whether it was on the ortho floor, whether it was on the ICU floor, they were co-treatments. And so I'm just wondering if you can maybe speak into their practice about maybe changing some of that behavior and just really kind of seeing the value. And Arnold, you already mentioned this opportunity cost, but how do we kind of challenge some of those newer grads that are a little bit fearful about walking into those situations?
Not only new grads.
Without having their
I was going to say, not even new grads, Leo. Some people have been doing it for years and change is hard. So I would say for anybody out there, really.
Mm-hmm, mm-hmm. I mean, I want to take a step back even in that question and say, what can we do to challenge our clinical instructors to help our students become the best well-rounded therapists they can be? Is it co-evaling and co-treating with our OT or PT counterpart? Probably not. And because if that's all they know, that's what they're going to come into the field with.
Mm-hmm, mm-hmm. I think along with it too, it's an intimidating place to work in an acute care setting. It is the Wild West. Who knows how the patient's going to behave? Who knows how their body's going to react to this new stimulus that's taking place? I think what can be done is we can have some standardized sets of procedure on how to properly titrate the level of therapy that the patient needs to have. We all get this training, but when we're in grad school, right? But to bring it to the Gemba, bring it to the place where it's actually happening with the patient, and set up standardized competencies of, I'm going to go with you as your mentor for X amount of sessions that you will just observe. Now you will perform it X amount of times. And now I'm going to let you go, but we're still in this mentorship phase. Having some kind of standardized set of procedure to let the person bud and grow and have that experience in a safe environment before we cut them loose. Unfortunately, what happens a lot of times is I graduate on May 6th, June 7th, my license arrived, and now June 8th, I'm working in an ICU. Well, yeah, I'm going to bring someone along to help me out. And while that's great, we trust, our education and everything like that. Sometimes there's some more mentorship, some more structure that needs to take place right at the site of the work. And I think we kind of gloss over that sometimes as professionals. We assume folks maybe know more than they do or have more confidence than they do.
And I'll add to that too. I think there's some hospital systems that are doing a fantastic job at competencies and onboarding. But again, there's no standard, right? So you hear stories all the time of PTs that just got thrown, they got shown where the socks were and where the oxygen tanks are, and here you go. And they're off on their own, right? And that is, thinking about that is terrifying. But, even in our hospital system, that still happened up until very recently. And so that is on the employer side, the employer assuming that a PT with a license should be ready to practice independently in that setting. And that was assuming that our educational systems are preparing students for that. And I, maybe an unpopular opinion, but I think that our DPT and probably OT as well, maybe even more so, have historically underprepared students for the acute care and especially ICU setting. Now, Ashley, I know you're an acute care educator. Leo, I know you are. I am as well. And, there are a lot of us out there that are changing this, but the historical thought, right, has been that ICU is not entry level. We shouldn't teach students this. But I ended up in an ICU as a new grad. Bryan ended up in the ICU as a new grad. Paul ended up in the ICU. Like, it happens every single day in hospitals all across the country. And so we as DPT programs or OT programs, MOT, DOT, are not preparing students for practice in this area. So we need to be simultaneously increasing education in our entry-level programs to prepare students for this, as well as increasing competencies, onboarding, and ongoing competency for therapists in those areas as well.
So I have a question. So for those out there who are currently co-treating and they're listening to you and they're saying, you know what, they're right. I kind of want to change practice where I work here. But let's say like there's a handful of them and then a big group of naysayers. Like what practical tips do you recommend for someone at an institution who's listening to this and wants to start making change? Are there like some tangible, like low-hanging fruit first steps they can do? Like what would you say to them?
I think to start off, I would just make sure it was clear to my best friend that I've been co-treating with for a long time that this isn't a breakup. We're still together. We're still buds. But I want to focus in on this for a little bit. And so establish that clear that this isn't, we respect each other's professions, and that's why we want to move forward with it first. And so I think it's important to establish that because this is clearly in the culture of OT and PT. Mm-hmm. After that, you might just have to be pragmatic about it. And if someone says, oh man, the patient's going to be wiped out if they have 2 sessions, then I think if I was in that position, I might say to my PT coworker, why don't you take the first session and then I'll come in afterward. Mm-hmm. Try to make it as easy as possible for the other person. Might be a simple starting point. And then you always go in afterwards. And I think they'll start to build their confidence and grow and start to understand where you're coming from. I think that's one good place to start. Hey, Bryan, what do you guys think?
I think another good idea too is I always think permanent change is a tough pill to swallow. Temporary change is a little bit easier. So if you make maybe like a quality improvement project around it and say like, hey, we'd like to try this on this unit or this hospital system and try it for a couple months and then collect feedback and kind of see how people are feeling about it, see if it made a difference in the way that you're approaching patient care. I think people would be surprised in the outcomes, especially from a qualitative perspective of how people feel about the value they're providing and the way that they're going about their day might surprise them. So I think trying to set it as a temporary thing, we're going to try this for 3 months and kind of see how it goes. If everyone hates it, it's terrible, we don't have to stick with it. But let's try something new and try to break the mold that way.
Mm-hmm. Those are great practical tips. I love those. But I'm also thinking like from, let's say there's a manager listening and it's like, I want all my PTs and OTs to stop co-treating. I'm going to go back and I'm going to make this happen. I feel like sometimes they take an all or nothing approach, right? Like no co-treating at all, like to kind of just get people out of it. But like, is there a happy medium, right? Like, is there a way they can not just say no co-treating at all and still enforce minimal co-treating or when it's only absolutely necessary?
I think when we started this, some language from our boss even was, our team, Haley, Paul, and I took it to the extreme, but our boss suggested if an AMPAC of 12 or less, do whatever you think you need to do. If the AMPAC's higher than 12, try to figure out a way to see them by yourself. And if you can't, talk to your colleagues. Say, hey, like maybe have that conversation. What can we do to have this patient have a PT session and an OT session? And what does that look like? And if there's folks that just don't even know where to start, it's a great way to have a collaborative approach to trying to figure it out together. And then you got to start somewhere. Pick an AMPAC number, pick a functional level, and then work your way down from there. So the more dependent patients.
Bryan, I love that. So we actually have a measurable metric. Here's the number. Okay, and let's at least start with that. And of course, we can always bring in our own clinical reasoning. This patient wasn't, maybe they were a 13, but based on how they're presenting, maybe, there's some guidelines.
Yeah.
And I wanted to take a step back too, in terms of co-treatment. What can we be doing especially as PTs, just to kind of help increase this alliance especially with OT? Because I feel that, again, for a lot of the OTs that I've worked with, it has been a challenge. I think, Paul, you've mentioned this before, and you mentioned at the top of the podcast about being confused with PT. And I know there's some departments where PT and OT, they never collaborate. So there's no interprofessional, interdisciplinary communication. So what could we be doing as PTs just to kind of help ameliorate that again, because I think if there's better communication and better synergy between PT and OT, the patient is going to benefit in the end. But it does start off with that mutual respect. But any basic tips that maybe we can share with some of the listeners that we should be more mindful of as PTs?
I think understanding your purpose is important, and having that clearly communicated among our allied professional staff would be one place that we could do that. And maybe that's a non-threatening way to do it too, a way that we can all work together. We even had, like little lunch study sessions where we'd sit together and honestly write down what is my purpose as an OT. What is the purpose, that we can provide? And if we're being purpose driven around what metrics or different things that we can move on, I think you'll start to see a natural delineation of form between the two professions. I think they're very complementary to each other, but I think just like me and my older brother are two different people, folks will be able to see like these folks are siblings, but they certainly have their own personalities if we're understanding what drives these groups of individuals.
That's great.
I also think that the interdisciplinary, there's a huge push for interdisciplinary education, interprofessional education certainly within our DPT programs, and I know within the OT programs here as well. And I think these conversations need to be started while students are in school. So, for example, in the acute care content that I teach, we do have students kind of, hey, take a minute, break up into a small group. Like we do a lecture on co-treating and the pros and cons, and kind of get them clinically reasoning about why or why not to do it. And then like, hey, here's a scenario. An OT comes up to you and says, hey, we have this patient together. What time is good for us to see him together? And a lot of people are like, how do I respond to that? Like, I'm new, like this OT's experience. How do I respond to that without breaking their heart? And so practicing kind of those crucial conversations and the mutual respect and setting themselves up. And it's like, you're not, degrading them by saying, I don't want to work with you. Like, it's quite the opposite. We want to lift up the OT profession and both our professions as a whole and do what's best for the patient. And so let's try to, outside of the hospital system, simulate some scenarios where students can practice that and start kind of clinically reasoning through things. I think, as I mentioned before, in the absence of guidance, we tend to do just what we see being done or what's easiest. And that's what happens a lot in acute care is like, I showed up as a student in acute care and all the OTs are like, hey, we're co-treating, come with me. And I'm like, oh, I don't know any different. Okay. And I go with them. That's all I know. I don't know any better. So having those conversations before they go out into the clinic and get them clinically, critically thinking about the why or why not, pros and cons of why to do it, I think is important.
I love that you all have started this conversation. Honestly, even though I was playing the devil's advocate throughout this podcast, I'm extremely passionate about this topic. And I wish I had heard people like you before I was in the hospital, because I remember like that's how it started for me. I was like, oh, we to go see this eval together. And I am not a very patient person. And it would drive me crazy just standing there waiting for ADLs, because I was like, oh my God, I could be seeing like somebody else right now. And I know the OT, the same thing, probably like, oh my gosh. But I love the idea of having that conversation ahead of time. So then you don't get into that, like, oh, if I say something now, I feel rude, right? Like setting those boundaries up front and those expectations. So we're not only doing what's best for our professions individually, OT and PT, but also for our patients. So
Ashley, would you say that it's important to have those acute conversations? Is that what you're saying?
I think that's an excellent point.
Yes.
Nice.
I got it in there.
Bringing it in. I like
You're a
it.
podcast, guys. You should have these types of conversations.
Maybe we should call our podcast Acute.
Yeah, the acute conversations.
Mm-hmm.
And along with this whole theme of acute conversations in the acute care setting, it's time for rapid responses.
Oh boy.
Yes.
Yeah.
Yes, it is.
So again, for our listeners out there that don't know what we're about to do, so we're essentially going to just ask some rapid fire questions for about a minute for our guest today, and then our guest, please just whatever comes to your mind first, just spit it out.
I think we're gonna have to do like a minute and a half because there's 3 of them to get them all in.
Are we gonna target each of them indivially, Ashley, or are we going?
I think that's probably the best thing to do. Yeah.
There we go.
First thing that comes to your mind. You gotta go quick. All right, I've got my timer ready. You ready, Leo?
Yep. You want me to ask first?
Yep. Ready and go.
Brian, give me a book recommendation.
Oh, You Can't Hurt Me, David Goggins.
Awesome. Great one.
Haley, what's your favorite way to exercise?
Skiing. Definitely skiing.
Love it.
Paul, what's your most favorite scrub color to wear in acute care?
Black. Very slimming.
Good guys always wear black.
Brian, are you a morning person or a night owl?
Morning.
Haley, it is 4:00 and you get called in to do another evaluation at the very end of the day. What drink are you going to drink before you go in and see that next patient?
Coffee.
Coffee. All right.
Paul, what's another podcast you would recommend other than Walking Home from the ICU, since we already said that one?
Oh, does it have to be healthcare related?
Mm-mm.
No.
Okay, I've been listening to the Jocko podcast lately. It's not going to be for everybody, but I've been getting into that lately.
Awesome. Brian, if you could have lunch with a cartoon character, who would it be?
Ooh. Oh, geez. Ah! That one really caught me off guard.
Wait, come on, quick.
Goofy.
Goofy. Good choice. Good choice.
Haley, if you could recommend another person to come on this podcast, who would you recommend?
I think you've already had some of my favorite people on here. I'd say Callie Dayton from Walking Home from the ICU podcast. Wes Ely from Vanderbilt, I think, has some great things to say. I don't know. You've already had a lot of my favorites.
Very cool. Paul, what's your most favorite dessert to eat?
Favorite dessert to eat?
Mm-hmm.
After a long day, you go into the nutrition room and you get a thing of the ice cream and you crumble up some of the graham crackers on top. And then you get a scoop of peanut butter and jam on there. You have a nice little sundae. So
Wow.
make sure the nurse manager doesn't see, though.
Oh my goodness gracious. Yeah, we would never steal from the hospital. No. So anyway, that's all the time we have, but you all have to answer our last question. You know you work in acute care when, fill in the blank. Brian, how about you first?
When you go home in different scrubs than you came to work in.
That's a good one.
Haley?
When you know all the alarms of all the machines and you hear them even in your sleep.
Yeah.
Paul?
Ooh, when you had to buy shoes in the middle of work.
Oh gosh. Haley, it's so funny you mentioned the alarms because my husband, I think I drive him crazy because whenever I put in the microwave and then I forget them, it just continues to beep and I'm immune to it. He's like, can you not hear that microwave beeping? I'm like, no, I can't, but thanks for telling me.
Nope, that's the background music to my life.
Just
Right.
background music. Yeah.
Doesn't faze me. I'm used to that. That's not a problem. That's okay.
Well, thank you all for coming on today. We really appreciate it. This was a really great, acute conversation. And I'm sure you'll be happy, hopefully, for us to put your contact information in our show notes if anybody wants to reach out and have more conversations with you about this.
Yeah, thanks so much for having us, Leah and Ashley. This is great.
Thank you.
We would like to thank Haley, Bryan, and Paul for joining us on the podcast. Acute Conversations is the official podcast of APTA Acute Care. It is hosted by Leo Argulis and Ashley Poole. Executive produced by Katie Brito and Edward Mathis. Music by Alexia Action from Pixabay. Sound effects also from Pixabay. For more information about APTA Acute Care, Be sure to check out our show notes for links and resources from the Academy. If you found value from our podcast, please be sure to subscribe, follow, and share with your friends and colleagues. Join us in 2 weeks for a conversation with Christiane Permy. Thank you for listening, and may your shoes and scrubs stay clean today.
We didn't really do anything funny, did we?
Paul, what's Paul's favorite snack in the hospital?
Oh, yes.
Ingredients for an acute care Sunday? Oh, we can title it.
Now I want to go get some ice cream.